So I'd like to thank Dr. Ramesh and Dr. Ramachandra for the invitation to be here. It's my second opportunity to be in India, and seeing my friend Dr. Santosh here, it reminded me the first time I was here, it was very apropos that this is now evidence-based and outcomes-based medicine, because that's the buzzword really in the United States, because we are suffering from the same needs that you are here. We have to prove that what we're doing is efficacious and of value. And when I was here last, I presented a very observational study. Now, it was a big study, 500 augmentations to show what the outcomes were. But really, what the next step was to understand what happened to those.
Who am I talking about in this? So I'm talking about patients who have neuropathic bladder, that's all, and they are patients who have sphincteric incompetency. So we're not talking about the patients who at the time of your assessment of them have high pressures and are incontinent, etc., such as in the top picture, because almost all of those patients, if they are treated early enough, will respond to anticholinergics and intermittent catheterization, and they don't need an augmentation for their, they don't need a bladder outlet procedure. So it's the other group. It's the patients who have come through infancy fine because they have an incompetent outlet and they tend to leak rather easily. And so at the time of when it's appropriate to work on them for continence, the question is, what is the best way to treat them? Do they need an augmentation in addition to a bladder outlet procedure? So as Mark's already mentioned, the beginning of treatment in these patients was putting in an artificial sphincter. Well, it happens that I did my training at Texas Children's in Houston, and right across the street from us was Brantley Scott, who really pioneered and pushed the artificial sphincter. And from the time that I was there and from what's published in the literature, it's hard to go back and look at those days and compare them to today, because those patients weren't evaluated the way we do today. They didn't have good preoperative urodynamics. They weren't on medical therapy like we would today. It was, we have a wet patient, we have a sphincter, and so they were put in. And similarly, after surgery, Dr. Scott was a big believer in not doing catheterization, so they had unsure emptying afterwards. But anyway, to take all the reasons why just putting in a sphincter shouldn't work, and yet what we see is that the minority of them ended up getting an augmentation down the road. So the question is, what is the indication? Pull out any textbook and look at the chapter on augmentation, and one of the first things should be, here are the criteria that say you need an augmentation. Well, you can't find it. You can't find it. We say that it's poor compliance, but what is poor compliance? We say it's not resistant to anticholinergics. Well, how much anticholinergics do you give, and when do you define that it's resistant? What is an insufficient bladder capacity? And then there's this issue of, well, patients are more dry if you do an augment. Is that really true or not? So again, I'm going to rely on some of Mark's data, because this paper, I think, is actually of great historic significance. And so it's worth taking one moment to look at it. And what you see is that they started out with 80 patients who had neuropathic bladder, and just based on the fact that there are a number of them in their institution and they had different reasons to do interventions, it turned out that about half of them had a prior simultaneous augment, so they're out. So then the other group, again, we don't know if there's differences between these or not, but this group of patients, for whatever reason, did not get an augment with their artificial sphincter. And as time went by, what they found is that a third of them, again, fitting in that overall category, somewhere less than half, ended up with an augmentation. You see the data right here. So then they took this and looked back and said, well, if we looked at their preoperative urodynamic, was there a difference in those that got augmented than those that didn't out of this group? And they said, well, no, there's not. There was a difference in them at subsequent follow-up as far as their capacity and their compliance. And so they said the preoperative urodynamic did not predict the need for future augmentation. So again, I'm not trying to be overly critical, but we're talking about evidence-based medicine, so let's agree from the beginning that we have to be careful with this data, because there's a lot of selection bias in it. Okay? But this paper, despite that, had a tremendous impact because as soon as people realized, well, my preoperative urodynamic that looks okay doesn't predict that the patient may deteriorate with time, really increased the number of augmentations. And at the same time that was happening, we shifted in the United States away from artificial sphincters to relying more on slings. And even though the sling has less outlet resistance, as he just said, the number of augments went up to nearly 100% in published papers. So we changed from doing sphincters and no augments to doing slings and routine augments. And again, I just point out, if we're talking about it from an evidence-based standpoint, there's still not a specific criteria. What's the volume? What's the compliance that says this patient is going to have an augment, excuse me, to protect their upper tract to become continent? And so, as I've said in some other meetings, I had a patient who died from rupture of an augment, and so that sent me back looking at this to say, well, did this patient need that augment? And when I couldn't find criteria, I thought, well, one reason we don't have criteria is just because we've had this low threshold to do an augment. So if we don't do an augment on any of these patients, the ones who need it will declare themselves. So that was the whole idea of it. And so, from the beginning, we decided, well, what's going to be the need for an augment? Well, that's going to be somebody that has high pressure, and using McGuire's suggestion, we said, well, that high pressure is going to be over 40 centimeters of water. And then they have to have something else. They can't just have the high pressure. They're going to need something else. They're going to need some upper tract change or incontinence despite medical therapy, and that's going to be the group that we're going to do an augment in. So first off, I started out by doing just slings, a 360-degree sling, and we did this on every single patient. I want to emphasize this, just as with the distal hypospadias, we don't select the patients. Once you start selecting patients, you introduce bias into it, and then you don't know what your results mean. So this is every single patient that we operated on once the study began who had these criteria: neurogenic bladder, non-contractile bladder on medical therapy, and they had a detrusor leak point pressure less than 50 centimeters or a smooth bladder, incompetent outlet. These are the patients, and every single patient like this with no selection initially underwent a sling procedure, 360-degree tight wrap with a Mitrofanoff. So this is what we did originally. But when we saw the results of this, because we're keeping this data prospectively, we're reviewing it periodically, when we saw the outcomes, which I'll show in a minute, the continence rate of these patients was not good, and it wasn't because of high pressures in the bladder. It was due to persisting outlet incompetency. And so I thought, well, the sling just doesn't coapt the bladder neck sufficiently or keep it sufficiently coapted. So I thought, well, maybe we can reduce the caliber of that neourethra. I'd worked with Mike Mitchell. He did this on the kids with extrophy, so I just took that same idea, did it in the neuropathic bladder patients, and then applied that 360-degree sling. So again, this is a time randomization study, as we talked about earlier. For these years, I did consistently this operation, and then one day I said, okay, I'm going to switch to that operation, and then I did that operation consistently on all subsequent patients. Just to acquaint you very briefly with this, it's a very straightforward procedure. We see that we isolate the proximal urethra, make an incision across the top of it from 3 to 9 o'clock, continue that incision on either side. So we're basically taking 50% of the urethra and lifting it off up towards the bladder. That's what you see here. This point started out down there, so we've lifted it up. And then we're going to tubularize that segment that remains, and then we're going to put a wrap around that. One thing that I discovered was that when I came through the bladder neck, you have to keep the strip the same width. If you get distracted and you allow that to flare on the sides, the patient will have an increased likelihood for persisting incontinence after the procedure. Now, what about postoperative management? It's not enough to say we aggressively treat patients. We have to say exactly what we do, because what you consider aggressive, what I consider aggressive, may not be the same. So here is exactly what we do. We give oxybutynin in this dose for 3 or 4 times a day, and then we will add intravesical oxybutynin for those patients who still need additional anticholinergics. So this is what we've done. Intermittent catheterization is every 3 hours during the day, and some patients had overnight catheterization in addition to that. The imaging was uniform throughout the entire study, including both imaging of upper tracts with sonography, and our urodynamic tests are done with fluoroscopy to monitor for reflux. So here's the outline of the entire patient series. So 85 children were treated during that time period. 3 of them had a primary bladder neck closure for technical problems during the time of the procedure when they were planned to have a bladder neck sling or a Ledbetter sling. The rest of the patients following the protocol had a bladder neck sling or the Ledbetter sling, again time randomized, and what you see are those patients, and what was dry was no pads. Dry is no pads. So using a very strict definition, only basically a third of the patients having a bladder neck sling became dry. Of the Ledbetter sling, 2/3 of them became dry. Out of all of this group of patients, 3 patients had an augment. I'll come back and talk about them. So we had 3 patients who had a bladder for reflux. Initial therapy, again, because these could not be done for various technical reasons. And then we had failures in this. These patients who were not dry, some of them then went on and had a bladder neck closure. So in altogether, we have a series of 23 patients who had bladder neck closure without augmentation, and we see that 2/3 are dry, and then another group were not dry. So this is the overview. This is what we got out of the whole series. Let me break that down a little bit to you. So let's compare slings and Ledbetter-Mitchell slings, and let's look at these factors to assess the outcome. Continence, again, dryness. Dryness meaning no pads. So 1/3 of the bladder neck sling, 2/3 of the Ledbetter-Mitchell sling, which was statistically significant. So if you're going to do these type of procedures, you need to make the bladder neck more narrow in addition to the sling. At least my data said that a tight 360-degree sling did not achieve dryness. Did not achieve dryness. If we add improvement into it, well, the numbers start looking like what's in the literature, but people protested that, and in fact, a patient who goes from wearing 5 pads a day to wearing 2 pads a day is improved, but they're still wearing a couple of pads a day. So really, we've decided to use the more strict criteria. What about upper tract changes? For this, I'm going to combine the 2 groups because there was no difference in the sling and the Ledbetter-Mitchell sling. And I'm going to say if you put all of them together, 25% of them had some upper tract change, some of them on the very first study, some at a later date. And this comprised new hydronephrosis or new reflux. But again, most of the hydronephrosis was mild, grade 1, grade 2, and it basically, as soon as the bladder was catheterized, it went away. So this was seen on surveillance ultrasounds. When they catheterized the bladder, there was no hydronephrosis, but we counted it nevertheless as hydronephrosis. We had new reflux in a series of these patients. Most of it was low grade. And what did we do with these? So for most of these patients, you know, we did updated urodynamics, we added anticholinergics as necessary, or we did deflux injection in them. And so what we do after we've done a bladder neck procedure on them is there's a 14 French percutaneous access sheath that is actually used for some kind of central line, so a laparoscopic port or something that the general surgeons use that y'all use, we don't. And that sheath actually is very easy to put in the bladder, and then the cystoscope goes right in it, and you can go right down and deflux. So it's actually very easy to deflux these patients, and that's when we see patients with reflux after these operations, we also believe that that's a risk factor for upper tract damage, and so we go right in and deflux them as initial therapy. So there's the outcomes. All of these, all the hydronephrosis went away just by reemphasizing intermittent catheterization or adjusting their anticholinergics. We had some spontaneous resolution of reflux. We had others that were treated with deflux or just increased anticholinergics, and a couple underwent reimplant because they were having additional surgery anyway. What about the bladder pressure changes? When do those occur? Well, our data with follow-up in this case out to 3 years said that it occurred in the first few months after surgery and then stabilized. Not an ongoing risk for deterioration over time, but a risk of it's a change right off. Now, is this a real change, or is this an unmasking of a problem once you stop the leakage? And I don't know the answer to that. but it occurs early, and then the patients tend to be stable or improve with subsequent medical therapy. Let's look at some bad patients. So we had this group of patients. I didn't know what I was going to encounter doing this study in this fashion. So I came upon some patients like this who had sustained elevated pressures greater than 40 centimeters of water in their urodynamic test, but they were clinically doing fine. What do you do with these? I mean, look at these urodynamic tests. Most people would take one look at this and say that's a patient who needs an augmentation, but the purpose of our study was to see if, in fact, this patient needs an augmentation based upon the criteria that I said originally, so we didn't do it. And most of them stayed just like this. The bladder appears smooth. Most of them didn't have reflux, and they're dry. They're not having infections. Their upper tracts are okay. Do they need anything? There's the patient with the worst bladder trabeculation, and he had this change on the appearance of his bladder. This is his 6-month urodynamic test. I have followed this patient for over 5 or 8 years now, and his bladder has never changed from that. He blew out those little like cellules, and then it's been stable ever since. So let's look at these. So this is my follow-up. So at 6 months after surgery, here was the mean for this group of patients. Here's the mean infilling pressure. 3 years of follow-up, the mean pressure is staying exactly the same. A third of these patients had upper tract changes. Again, most of this was mild and resolved with medical therapy or deflux. You can disagree. My point isn't to make converts of you. My point is to present the data and allow you to analyze this for your own practice too. So what we found was that pressures above 40 centimeters of water that had reversible upper tract changes was not an indication for an augmentation. So how many augments did we do? Well, in that group of patients with Ledbetter sling and bladder neck repair slings or Ledbetter Mitchell slings, only 4% of them. So one that had a Ledbetter Mitchell sling from the very first postoperative urodynamic and continuing after that, despite increasing anticholinergics to tolerance, that patient just had persistent elevated pressure and bilateral grade 3 hydronephrosis. It's the only patient in the group that had sustained pressures that didn't respond to therapy at all with hydronephrosis, and so there was nothing else to do, and I did an augmentation for that patient. One patient who had low capacity, this is kind of a complicated patient, and I've reported him. Let's not go into all the details, but let's just say, okay, one of the bladder neck sling patients had an augmentation at the time that I closed his bladder neck. And then one patient was operated on by another surgeon the patient had no problems urodynamically, but complained of suprapubic pain of short duration, and the surgeon took him straight to the operating room and did an augmentation. So let's look at bladder neck closures for a minute. So again, this is the group of patients. There are 26 patients with a bladder neck closure for the reasons shown there. What are the results of these? So I have follow-up in 23 of those patients, and here's the results. So most of them are dry, but some are still wet, and so I've done 7 augments out of this group. So my continence rate is 65%, but for reasons I'm going to show in a minute. Upper tract changes, again, occurred in a group of these patients, and we did an augmentation in a third of these patients, which is obviously quite a bit higher than in the patients that had a sling or a Ledbetter Mitchell sling. So what was going on with these? So there were 2 reasons for augmenting them. One patient all of these patients had high bladder pressures. All of them had high bladder pressures. So one of them had bilateral hydronephrosis. He was dry. He had no other symptoms. His creatinine was stable. There was nothing else going on, but he had persistent bilateral grade 3 hydronephrosis. And so I thought, this patient most likely is safer with an augment than without. So that patient had an augment. The other ones all made their own pop-off mechanism. So when Mark said earlier, having a little pop-off from these patients, the patients who are totally dry probably pop off a little bit from Ledbetter Mitchells or slings. And when you close the bladder neck, then those patients may not pop off at all. So these patients began to leak out of their Mitrophanoff when they had previously been dry. Well, any of you who do this kind of surgery know that occasionally a patient who's been dry from a Mitrophanoff will begin to leak. And so my first thought was, sometimes the tunnel shortens itself in some way. Sometimes we've had some patients who have dehisced the distal end of the Mitrophanoff with their overnight catheter. For various reasons, we've seen leakage. So my first response when I saw these patients with leakage after bladder neck closure was that, well, they've just developed some technical problem with their Mitrophanoff. So I revised the Mitrophanoff, and they persisted in leaking. And finally, the awareness came to me that the problem in these patients is, in fact, this pressure with the leakage. And as you see, of these 6 patients who had this secondary leakage, in five of those 6 patients, they all ended up with pressures like this. They originally had low pressures, developed these high pressures, and began to leak out the Mitrophanoff. It was hard to assess that originally because they were leaking out the Mitrophanoff, so it was hard to see that high pressure originally. One of them had pressures of 40 centimeters of water that went up. So these are the patients, and this is the reason why we did an augmentation after the bladder neck repair, bladder neck closure. So if we look at the overall series, 14% of patients, using the criteria that I did, came to an augmentation. So were there predictors for this? Well, the preoperative urodynamics did not predict, just like Mark had found in his series. The urodynamics did not predict those patients who eventually came to augmentation versus those who didn't. The criteria were those that I said from the beginning: high pressures with a secondary problem, upper tract change, and/or urinary incontinence. And this data has all been submitted for publication. So here is the preoperative urodynamic test looking at infill pressures, predicted percent of volume, etc. And you see there was no difference in those patients who were augmented and those patients who weren't, looking specifically at the patients who had bladder neck closure. So again, the preoperative urodynamic parameters did not predict the behavior of these patients after the bladder neck was closed. So I thought it was kind of fun to look at my data and look at Mark's data, and we see it's very similar. If we look at the preoperative percent capacity in those that were augmented, it was the same. The postoperative capacity was the same. Isn't that interesting? His compliance was higher than ours in those who were augmented, but it had decreased by half. Ours had also decreased by half, and these were our infilling pressures preoperatively in these patients versus postoperatively in those who came to that. But I want to stress that if you just go by, quote, insufficient capacity, of these patients who had a 40% predicted bladder capacity, well, we had several patients who did just fine with that and didn't come to an augmentation. So again, we have to be very careful in using these numbers, because the numbers alone don't tell us who may need the augmentation done. So what are some criticisms of this? Well, some people criticized this initially by saying, well, your patients are less dry. And so when we originally reported this, that we had this number, well, that's the same as what's basically been reported in most other series using a bladder neck sling. Our results are significantly better by making the bladder neck smaller and then applying the sling. We give too much medical therapy, and patients are going to have a decreased quality of life from that. So to answer that question, we had an evaluation of patients who had been augmented and those who had not been augmented returning to our spina bifida clinic. And we looked at the frequency of intermittent catheterization and their anticholinergic use, and there was a half-hour difference in CIC in those who were augmented and those who weren't. There was an increased use, of course, in anticholinergics in those who were not augmented versus those who were. But in our health-related quality of life review of these patients, there was no difference. So from the patient standpoint, we didn't see a difference that they reported to us on the basis of having to use anticholinergics. When we submitted these papers for publication, we were criticized for having a high rate of upper tract changes. I've shown you that data very transparently, about a third if you average it all up, but most of it was low-grade hydronephrosis or reflux, and it did not need further surgery to correct it, except for perhaps a minimally invasive injection of deflux. We don't have any renal function data. Now, there's the most important criticism of the paper, and if I had something to do over again when we set up this protocol, I wished that I had set it up using DMSA, but at that time in 2000, we weren't doing DMSA like we are today, and I didn't think about it, and we weren't doing creatinine clearances, et cetera. So, but this isn't unusual. I mean, we've already talked earlier today that we don't have renal function data. Mark said in his patients he doesn't have renal function data either. So that's a problem of our profession, that we haven't been, we've been happy with serum creatinines and renal ultrasounds. So this is a problem, and this is particularly a problem because the question on those patients who have persistent high pressure without hydronephrosis or reflux, are we harming their kidneys? Well, by serum creatinines, we're not, but whether over time that will show a change, I have no way to know. But again, we just don't have renal function data for any of these groups of patients, and we definitely need that. So I'll conclude by just summarizing all this. What have we learned through this time? Well, first off, again, if you're involved in this work, a Ledbetter-Mitchell sling gives a statistically better result than a sling, and it's not much different. It's not a technically difficult thing to do, and so I would strongly recommend that you consider adding that to your procedure if you're doing outlet procedures for spina bifida. The preoperative urodynamic does not predict the postoperative course, so 2 studies have shown that. The pressure changes in our series, except in the bladder neck closure patients, were mostly seen on the first urodynamic test. Our data shows that pressure greater than 40 centimeters of water alone is not an indication. Just the appearance of that urodynamic test is not an indication to go to the operating room and do an augmentation, and neither is the initial appearance of hydronephrosis or reflux without an attempt at medical or minimally invasive therapy before proceeding to it. The bladder neck closure, not surprisingly, has the highest risk for adverse changes and need for an augmentation. And so the indication for augmentation, when we boiled all this down, was a combination of very high pressures, actually, as I showed you, over 80 centimeters of water, plus persistent hydronephrosis or incontinence out the Mitrofanoff. We found no difference in health-related quality of life, whether we had these patients without an augment versus those who had an augment. And so basically, I think we can at least agree on this. Maybe I have augmented too few patients. But if I have, maybe we can also say that the folks in Indiana and other institutions have augmented too many patients. And we should really use our efforts to try to find what is the correct balance of continence and bladder storage and pressures. And I think today we don't know that, but after looking at the list of potential complications that come from an augmentation, we should all be a little cautious at rushing to that, knowing that at either extreme, without an augment, with an augment, we face the potential. We don't operate on these patients and walk away from them. You can say, well, your patient's going to have to be followed forever. Well, Marcus said the same thing. His patients need to be followed forever. So if you embark on caring for children with spina bifida and you operate on them, they need to have, indefinite follow-up. And lastly, I just want to leave you with this. If a preoperative urodynamic test doesn't predict the postoperative course, stop using it to predict what you're going to do. Simple enough. It's hard to tell in a patient who's incontinent what their postoperative capacity is going to be when you improve their continence. So Dr. Cain has shown it, we have shown it, that preoperative urodynamics do not predict who's going to come to an augment. Yet every day, surgeons in the United States and around the world look at a urodynamic test and say, you don't have a big enough capacity, your pressures look a little worrisome to me, you need an augment. If they don't predict postoperative course, we should quit using them to predict postoperative course. The reason for a preoperative urodynamic is mostly to see if your preoperative medical therapy has been sufficient that you have no other recourse except to operate on the bladder neck, not as a reason for saying you need an augment. Thank you for allowing me to speak on that subject.
Thank you. Any questions? Dr. Sudipta?
Hello. You've shown very convincingly that augmentation is not necessary in that group of patients, of selected patients who are leaking because of sphincter incompetence. Now, that conclusion itself is somewhat based on an urodynamic study, is it not? That they are leaking from sphincter incompetence.
Well, I showed how do you diagnose sphincteric incompetence? So I showed you the diagnosis, the criteria that we use to make that diagnosis.
Another question I have is,
Can I interrupt to say this? You know, in the United States, the majority of patients, at least that we've seen, and our center was a referral center for the entire state of Texas, so we see a lot of patients with spina bifida, okay? Most of the patients who come to us are still responsive to anticholinergics. We have a few patients who wander up from Mexico where the care is not so reliable, and some of them come in already in renal failure at age 8 or 10 or something. They've had no therapy at all, and some of those patients, when you give anticholinergics for a high-pressure bladder, it doesn't respond. So I suspect that some of these bladders become fibrotic over time, so not all of them will respond, and some high-pressure bladders will need an augmentation. But that's not the group of patients that I was talking about.
Yes.
I'm specifically talking about that group of patients who has relatively lower pressures, and they leak because the outlet is incompetent.
would you say that if you on a VCUG study, if you see any trabeculation or particularly reflux, would you opt towards an augmentation rather than bladder? Would you do the surgery if there was any indication of a reflux or a trabeculation on the MCU?
Well, again, what I showed you was that our patients were not trabeculated,
Yes,
and
yes.
I think if you see a bladder with trabeculation, you have to have some concern about why is it trabeculated, and so the series of, meaning what is the pressure. So again, the series of patients that I showed you a representative picture of what the cystogram looked like. These are smooth appearing bladders that leak. So again, I'm not, and you have to be careful about that in everything that we report. That's why we have to be very clear about who are the patients we're doing. So I didn't select within that group of patients, but I selected that group of patients. So a patient with trabeculation is not in this group of patients.
Two little small points. One
Sure.
is I think your last conclusion is the most important one. It's the
Okay.
volume and pressure when they catheterize that really matters.
Yes.
And I think that's the take-home message
Yeah.
for everybody here. Because if you have a leak point pressure of 80, but no hydronephrosis, and you catheterize at half that volume and have a pressure of 40, you're probably going to be safe.
Right.
Just like you're saying, for a long, long time. Because your pressure and volume specific on your cath diary puts you in the safety. Right? Would you agree? And then overnight
I
cath
do.
too. The percentage that
Yes.
need overnight cath may be a little higher, but that also patients do
Yeah.
that and they comply with that, and it's not a big deal. So I just wanted to. You do
No,
do
that's very
voiding
fair.
diaries, right, on all these kids, and make sure they're cathing at volumes that are relatively
Well, we do.
safe. And
The issue, I mean, you know, so again, like everything, we can talk for a long time.
Right.
But one of the problems with the urodynamic that you know and I
it's a
know,
single test.
it
isn't
is,
Yeah.
and very frequently, you know, even slow fill is faster fill than what they do at home naturally, and sometimes these kids have learned, because they have so many urodynamics, that when they say, "Oh, I'm full," well, then they turn off the study and they can get out of there. And so when you ask mom, "What is the volume you get when you catheterize at home?" and they may come in and say, "Well, we get 350 cc's." You do your urodynamic test, and the child is complaining of discomfort at 200 cc's. Well, the urodynamic test may not reflect the actual circumstances that the child lives under. The other thing is these bladders are less elastic. I mean, if we use a really easy term, they're less elastic. Perhaps the faster you fill them, you see that emphasize more. So even slow fill urodynamic in an inelastic bladder may show you higher pressures than what actually occur with a slower fill at home with natural filling from the kidneys. And so then you add on top of that, maybe they never get to that pressure, and then you're regularly emptying them and resetting things. And that's, again, more reason to say urodynamics are a guide, but they're not an indicator of what we should do for therapy. So we agree completely.
I think we agree completely. The second, I was the reviewer that said, you know, I don't necessarily agree with all this, but I think it's good to challenge and get this out
Yes,
there.
good.
But also said that DMSA was critically important.
Yeah.
And the reason why,
Yeah.
I think, is that it's apples and oranges when you compare somebody that has hydronephrosis and a normal creatinine and somebody that has completely resolved hydronephrosis after an augmentation
Right.
that's continuous over 10 years with a
Right.
normal creatinine. I think those are two different risk patients, and that's why I think it's so critically important you come back in 5 years with some DMSA data on these patients.
Yeah.
If we're going to change what we're doing, I think it'd be really good to show that. Because, if you go back, those patients that did poorly before in the 70s were those patients that had scarring and hydronephrosis. Those are the ones that had
Right.
mortality back in the early 70s. And we've changed all that. And it's okay to say we're going to accept something different. But I think, again, let's get really, really good data when we're going
Right.
to change things. That's why I would.
Well,
that's why
and
I
let
would
me
point
make
it
clear, too, that I wanted to be very liberal in reporting adverse outcomes, and so when I report these hydronephrosis data, for all of those other patients, except for the few that were augmented, literally those patients came in, and you know this, they come in for their ultrasound, the radiologist says, be sure and have a full bladder, and so they haven't catheterized, they go in, they have grade 2 hydro they didn't have before, then they say, now catheterize your bladder, and then there's no hydro there, and then we follow those patients, and many of them never had hydro again, but we still reported that as an upper tract change. I completely agree that those patients who have persistent, especially grade 3 or more hydronephrosis, I was not comfortable to sit on them for longer time either. So again, I think there's less difference between us than what you might think right off.